very important to get controlled drugs correct. We've got a legal requirement to keep the records legible without crossings out, Tipex, and any omission recording. Need to have robust documentation and recording for every dose applied and administered. We actually had a CQC inspection in 2018, so I'll hold our hands up. We were told that we had to improve, and we had to improve our compliance and recording with controlled drugs. So what we did is we thought, we're never going to get this right on paper because staff are always going to cross things out, really easy to get things wrong. So we went out to the pharmacy IT community and asked if there was anybody out there who was able to supply us with digital controlled drug registers. And at the time, so I think it was 2019 by the time we put this out, there wasn't any suppliers out there who were doing controlled drug registers, controlled drug ordering systems that did the whole system for pharmacy and the wards. But what we did find is a company who were prepared to work with us and build us a product that was bespoke for us, but hopefully also would be transferable to other trusts as well. So that's what we did, and we did it also because there was a lot of wasted nursing time in delivering paper books to the pharmacy. Next slide, please. So we put a project structure together to deliver this. We had pharmacy and the clinical teams. We had some project management support from our IT department, who were called the Health Informatics Service. And we also found the company that were providing the digital package, and they're called SolidSoft. Next slide, please. So if you don't know the area where we're from, it's Calderdale and Huddersfield, and this is where they film Happy Valley. And if anybody's seen that, there was a Calderdale pharmacist there who didn't manage his controlled drugs correctly. So I'd just like to say that not all Calderdale pharmacists are the same, and we've put something much better in place called ECDR+. Next slide, please. So our aim was to replace a paper-based system. So this is what our old controlled drug registers used to look like out on the wards. So nurses can now order CDs digitally from pharmacy. Registers are all totally digital, totally paper-free. So we've got improved CD documentation and audits. So we're saving lots of time, but we're improving accuracy as well. Next slide, please. So ECDR is from SolidSoft. It's now live across Calderdale and Huddersfield Trust. We're 2 acute trusts. In Yorkshire. We went live in January 2023 after, I'm going to say, about 2 years of designing and building the project. So it took quite a while for engagement, training, etc. So now totally paper-free. We can order CDs from pharmacy digitally, and also the inpatient pharmacy is totally paper-free as well. We think we're the first trust in the UK live with this system. We've co-developed it with SolidSoft, and we involve lots of clinical staff with testing. Next slide, please. So this is what my screen looks like in pharmacy when we start in the morning. We've got all of our orders already in, so you can see that the new orders are there from all of the wards. Usually in our trust, the wards order CDs overnight. It's usually the night staff that check the cupboards and order more drugs. So we don't have to wait for the CD books to come down to pharmacy. They're already there. And this is like the pharmacy dashboard screen that we can see. We can see what orders are ready for collection, what orders are in transit. We can see all the approved stock lists for the wards. We can also look at our own CD compliance audits, what our current stock levels are, what CDs have been returned. We can add patients to it. We can dispense prescriptions. We've also got a whole workflow for disposing of illicit substances and unwanted CDs, etc. So actually, it's the full shebang. Next slide, please. This is what my pharmacy register looks like. So it's all in alphabetical order. I can see exactly what drugs I'm keeping and how many I've got. If I get a new drug in, I can add a new supply, and I can do a stock check as well. Everything is time-stamped, everything is accurate. So it works really well. Next slide, please. I've got a full audit trail for each drug and transaction. Just looking at this is my CD register for a particular drug. So this one is for morphine sulfate injection. I can see my running balance. I can record a discrepancy. I can show any kind of history, and I can see there who's been supplied and what time it was supplied and who supplied it. So all nice and legible and time stamped. Next slide, please. So in terms of training, this is our training team. So the project's been on quite a slow rollout from January. We've gone live one ward at a time. And this was purely a choice from the nursing side. To be honest, on the pharmacy side, we would have preferred to do like a whole big bang go live for everybody to go live all together at once. That would have been much better for us and to get the system in. However, when we engaged with the clinical teams and the nurses, it was the trust choice to do a slow rollout. So we went live slowly, ward by ward, and we found that the nursing teams needed a lot of support to go live and to get trained. So what we did is we put together our own pharmacy training team. We didn't want it to be an IT training team, because obviously when you're out on the wards, you get a lot of questions, clinical questions about controlled drugs, and upskilling an IT member of staff to do this, I think, would have been a challenge. So our training team is made up of Carol, who's a nurse, and Sue Walker, who's a pharmacy technician. So they've both got, they're both experts in their fields, nursing, pharmacy, and they're great. They're really friendly. They go out to the wards and engage with them. They can answer any questions. So we've been doing one-to-one training of the nursing staff, and we find that was the best way to do this project. So we've been going live ward by ward. Also, the challenge was with training nursing staff as well, especially nurses that work night shifts. They're not always available to be released for training. So Carol and Sue have been going in on night shifts as well to train people. So here they are in pharmacy, just enjoying using ECDR. Next slide, please. So the benefits for the wards department of pharmacy: lots of saving times, avoids physical transfer of CD books, no delays caused by the staff ordering CDs or on your signature list, much quicker. We've got a real-time dashboard, so staff on the ward can see the status of all orders. So they don't need to ring pharmacy anymore, because they can see on the screen the status of the order. We've got a stock check function, so the actual stock balance is checked at every administration, and we get a second checker where that's needed as well. They're all mandatory fields. System can highlight discrepancies instantly, and in the event of a stock shortage or out of hours requests, the system's searchable as the data is all real time. So it's really good as a pharmacist on call if a ward rings you because they want a certain strength of buprenorphine patch. We can find that really easy out on one of the other wards and just ask them to borrow a dose overnight. So great for us too. In terms of daily stock checks, we find that these are much quicker now. We get instant reporting of any deviations, and the system can also automatically flag any concerns, such as up to the chief pharmacist or director of nursing if anything's kind of, if there's any discrepancies. And there's no more paper registers or order books. Next slide, please. So this is some of our feedback. We've had some really good feedback. Deputy Director of Pharmacy has given us a compliment that she was on call and she could find out exactly where she could find a drug, and it saved at least 15 minutes of her time. The staff comments are it's easy to use, it's user friendly, it's quite straightforward, it makes ordering much quicker. Feedback from Ward 5 is so far the feedback's been really positive. Nursing staff have said the system's easy to follow, and the more they use it, the easier it is. So yeah, really good feedback so far. Next slide, please. So where do we go from here? Obviously, there's always things that you can do to improve your system. What we'd really like to do here is streamline access to the system, because currently it's like a separate log on, whereas most of our other systems here in the trust, it's like a tap and go type system. Also, we'd like to be able to access it on a mobile device at the patient's bedside. We're going to put that on the future roadmap. We'd like to integrate it into our Cerner EPR record, but also our EMIS pharmacy stock control system. But we realise that's something in the future. It's not something that we could have gone live with. We went live with something called a minimum viable product because it was kind of first of type, because we built it with the company. We couldn't have everything ready all at once for go live. So that's integrations on the future roadmap. So now we are live. We are the only trust live with this. We're now the go-to reference site for any other trust. If anybody's interested or wants to come and have a visit or a virtual visit, I have done some virtual Teams meetings where I've shown this product to other hospitals. So yeah, happy to take any questions or have any chats offline. Just let me know. Next slide, please. And so that's all from me about electronic CD registers. And at this point, I'll hand over to my colleague from CHFT, Jim Harris, who's going to tell you about another project that we've managed to get live, which is our EPR to EMIS interface. Thank you, and over to Jim.
Hi. So with apologies, I'm reusing a presentation here that previously used for a non-technical, non-pharmacy audience. So we'll kind of canter through that, and then I've got kind of some more technical stuff at the end. Next slide, please. So our goal with interfacing our EPR to our pharmacy system was to improve patient safety, to digitize and streamline the entire process of nurses requesting pharmacy supply medication, and just reducing the administrative burden on pharmacy. It sounds straightforward, you know, it's something to non-technical audience that it should be really simple, but it was an 18-month project and an enormous amount of overtime and kind of corralling 2 different suppliers and a trust IT and a clinical team, so it was quite hard work. Next slide, please. So previous system was ripe. We were rekeying stuff from our EPMA into our pharmacy system. So lots of unnecessary work, lots of potential for transcription errors. We could get the wrong patient, we could get the wrong encounter, we could get the drug wrong. I don't think I need to explain transcription errors and how common they are for this audience, but also it needed a further safety step, you know, to double check. Next slide, please. So 3 years after we'd gone live with our EPR, we were still getting nurses to write on sheets of paper and trundle around the hospital with their order to bring it down to pharmacy. In 2020, as part of our COVID response, we kind of built a form within EPR to for them to kind of free text an order, which would send a task to pharmacy who they would process. It worked. They loved it at the time. It was better than what they had, but it was a lot of free texting and lots of keystrokes, lots of potential to get things wrong. As part of this interface, we switched on to as kind of med request, which reduced everything down to just tick the meds you want and click submit. So we went from 64 keystrokes down to just 5 clicks. And if you're only clicking stuff, you can't mistype things. Next slide, please. And this is click, tick, submit. This is all they have to do, and it shows them that they ordered something yesterday or something like that, or it had been sent weeks ago. So very intuitive for nurses, so and hugely popular. Next slide, please. So hugely popular with nurses, an easy win, that one. Next slide, please. The pharmacy process, I've tried to do the same thing, but there's so many things. There were so many clicks in the original process that it's hard to grab on a single slide. But you can see that big gap where instead of retyping information that was already digitally in one system into a second system, we just skipped straight through that. So next slide, please. So not as dramatic as it was for the nurses, but we went from 61 keystrokes to 13 clicks to send it across from EPR to pharmacy. Next slide, please. So it's a quick process. Where it works is a quick process, very much streamlined. So it takes, you know, on average less than a minute to send things across. And to be honest, a lot of the average was pulled up by people that were clearly interrupted by phone calls and stuff like that. But massive time saving for pharmacy. Next slide, please. And we worked out that it was saving 440 hours of pharmacist time of needless typing, which equates to like 59 days a year. This is for kind of two hospitals with a shared bed base of about 900 beds. So a huge time saving. Next slide, please. Again, popular with pharmacy, and also the kind of eradication of transcription errors. We've not seen any transcription errors going from one system to the other where there's been an interface issue. Obviously, enormous amounts of double checking there. Next slide, please. Looking ahead, our EPR is a shared instance. So we share it with Bradford Royal Infirmary. So they don't have this functionality at the minute. That will be rolled out to them this summer, that they need to upgrade their EMIS. That's their next step. And then we've got Airedale, another neighbouring trust, joining our instance in summer 24, and it's likely that they'll go live with this as well. Next slide, please. So we've managed to hit all of our aims really. We've improved patient safety by getting rid of the transcription errors. Everything's slicker for everybody, really, for nurses and for pharmacy. People aren't wasting valuable clinical time retyping things into second systems. Next slide, please. So essentially what we did was to take kind of the best bits of our two supplier systems. So Cerner's medication request that we had the screenshot with is fairly standard, but we never went with it because its output was a sheet of paper in a dispensary, whereas we were working doing supply requests out on the ward and entering them in there. So kind of pharmacy, we didn't want the transcription moved down to pharmacy. We wanted the transcription staying, or the entering staying up at the top. And then EMIS's EMM workflow, which is where you create the medication and the supply request and the clinical check. So 3 elements. Creates a work list for the dispensary to work from. So it's a very efficient way of doing it. But at the start needed kind of laborious rekeying. So we kept the best bits of both systems and jettisoned the worst bit. We had to upgrade our EMIS to a version that could cope with it. So 20.18, that needed us at the EPR end to kind of pause for 6 months whilst they did that project. And at the EMIS end, we also needed to be using that EMN functionality, which our next two trusts come on board aren't using currently, but is a necessary step because we basically replicate that to send the message across. We weren't a trust that did barcode scanning where the system's capable of it, but we hadn't configured it. So we had to build a parallel product catalog to send it across to the EMIS system. Rather than using the kind of VMP level order paracetamol that the EPR uses, we need to match it across to usually a VMP to be able to send it across. So a lot of work creating that product catalog and deciding which should auto assign and which shouldn't. So that was kind of the largest piece of work there. We built an interface coming out of EPR out of Cerner EPR that matched EMIS's requirements. So we did a lot of bending of what Cerner did. EMIS kind of stated their spec, and we just had to keep bending to meet that. And lots of kind of aliasing the messages across. It's based on HL7 at the time, so with 20.18, EMIS couldn't cope with FHIR at that point. But it's not a transfer between hospital settings, it's an internal process. So we're kind of okay on that score. And then my biggest anxiety was the strength of this system is that pharmacists don't technically need to go into the pharmacy system at all now, with some exceptions. And my worry is they would send a dispense message out of Cerner EPR and it never reach the dispensary EMIS, and the dispensary not realizing there was a message coming. So with our reporting team, we kind of built a report which catches the failures we do get for various reasons, and kind of creates those into a tickable to-do list that the dispensary managers monitor and kind of pick that up, so we don't see any red list drugs falling into some kind of black hole. Next slide, please. So obviously we need to migrate the message to FHIR at some point, so that's the work which has been scoped at the minute. The process functions best because of a limitation of Cerner as an inpatient workflow, which is what it was conceived and bought as. Discharge meds work in a different way in Cerner, and they will go across, particularly if they're oral solid dosage forms, so very straightforward VMPs. And it's to do with how we do that order paracetamol to product, paracetamol 500 milligram tablet linking. The discharge meds kind of don't qualify for that, so that's a difficulty. It's a difficulty for all interoperability things with Cerner, so EPS is kind of pushing development there at the Cerner level, so hopefully that will be resolved in the future. Some classes of meds, so dressings and feeds, because of how DM&D works with no kind of VTM at the top, they don't match across very well. So those we will tend to still manually transcribe across. It's created a maintenance burden we didn't have before, of keeping a product catalog up to date, which we didn't have. And then the SNOMED CT UK drug update is kind of spoiling my Wednesday evenings for an entire summer, as we have to kind of retype all those numbers in, which I think we can thank Shazad's team for. And then there's things like, so EMIS can only cope with 250 characters in the message, and if you have a long insulin type name, and Cerner has kind of special instructions boxes where clinicians can and do sometimes enter War and Peace type instructions, that will cause the message to fail. That's our most common reason for the message to fail, and the reason why the reporting safety nets was so important. And then currently it's one trust, it's live at, it's serving one formulary basically, and when we roll out to a second trust which keeps slightly different drugs, different suppliers and stuff like that, there'd be some flexing we need to do and some kind of maintenance to make sure there's no misselection issues at the Cerner end before we send the message out. Again, I think we're in contact with most trusts that have the Cerner EMIS combo, so they're already in touch, but if anybody has any questions, happy to be contacted directly. We're at ePrescribe@this.nhs.uk, and happy to answer any questions in the chat. Thank you.
Just want to say thank you to Jim and to Penny for really, really innovative presentations there, and to showcase the great work you guys have been doing. Jim, Penny, are you okay to take a couple of questions?
Hello, yes, I've been trying to answer them in the chat, but yeah, happy to take questions if there's any. Yeah,
brilliant, thanks Penny. So again, just thanks to you and Jim for showcasing everything. I think there's a few that's been running the chat, so I don't know if you've answered them already, but just thought I'd just bring out, there's one, for example, which has a theme around integration. I think Megan, Cassie and Chandni have been asking about does the CD solution that you're talking about, is it integrate with Omnicell, Careflow, or any other EPR, EPMAs? I think you touched on it, but would you care to elaborate?
Yeah, so that wasn't something we realized we'd be able to go live with, just because of cost, but also because of time, and also because of our pharmacy stock control system is EMIS, which is notoriously difficult to integrate with. So we've put that on our future roadmap, but we wanted to be realistic about what we could achieve and what we could afford. And actually, when we did the kind of pilot system of a standalone system, it actually worked so well that we kind of put the integration piece further into the future. We had a lot of stuff happening at the time. We've got a new robot project. We've got lots of Omnicell cabinets. We were going live with the Cerner EMIS interface as well. So it's just not possible to do everything all at once. So it was a cost thing that stopped us from integrating with EMIS, because that would have been ideal. But actually, because the standalone system itself works so well, and it was just a cost thing. But the company are really, really keen for integration. I know they're in lots of conversations with EMIS and JAC, or Careflow, as it's called now. So yeah, that's definitely for the future, and also Omnicell as well. So that's the answer to that. I've been trying to answer the questions in the chat to kind of explain that a bit more. Thank you.
That's great. Yeah, and that like you said, in terms of the cost in the NHS as well, to have the appropriate funding is always quite challenging. So well done to you guys for actually achieving what you have done so far. It looks really good. I think there was another couple of questions as well I might just kind of touch on if we have time. So the other one was around, I think Sophie had a question in terms of ordering. How do you comply with legislation and needing a signature and indelible ink?
So I think we've rewritten our medicines code to reflect what is also. We went through medicines ethics and practice with the RPS, and we rewrote our trust medicines code, so we don't need a wet signature for stock ordering of CDs, and also for individual patient ordering of CDs. So there's lots of legislation changes, I think, are coming, but we kind of made the most of what the legislation is now. We still get our CD TTO prescriptions with a wet signature currently, but I think even that's changing quite soon, isn't it, for secondary care? But yeah, the wards, we don't need wet signatures from nurses from the wards for ordering CDs.
Yeah.
Thank you.
Okay, thank you. And trying to see if there's any other questions around presentation that Jim has done, just to kind of share that kind of the questions between yourselves. So
I'll answer them in the chat to not take up Angela's time, if that's okay.
Say that again, Jim.
I'll answer them in the chat, as there's only a couple, so I don't want to bite into Angela's time too much.
Yeah, no, that's fine. Okay, yeah, just want to say thank you again to yourself, Jim, and to Penny. I think that's really, really useful. I think it's sure that people reaching well to try to understand and kind of learn the lessons that you guys have learned from actually, doing this kind of work, and also then challenges in the future roadmap afterwards. Yeah, thank you very much. So checking, is Angela online?
Yeah, there we go. Hi.
Hi, Angela. So yeah, so thank you for joining. Thank you for taking the time to present today. So just to introduce yourself. So from what I understand, you're currently working in Health Education England and National Institute of Health Research. You're doing a clinical doctoral research fellow at the University of Bradford. You're working one day a week as a clinical pharmacist and informatician at Leeds Teaching Hospital, and looking at exploring the cultures and behaviours evolved in response to technology use in healthcare and medicine optimization approach. You're also a keen advocate of patient involvement in research and clinical activity. And as part of the extensive experience you've got, you worked for 23 years in hospital pharmacy, in surgery and HDU, as a teacher practitioner, ACP, and involved in implementations of EP systems in the Associated Transformation Project. And also, just to add, you're a clinical fellow, leadership fellow alumni, and a member of the RPS Digital Expert Advisory Panel as well. So yeah, Angela, thank you for joining, and yeah, I'd love to hear what you've got to say.
Thank you, Suzanne, and good afternoon, everybody. And it's great to be here to have this opportunity to share this with you. So the thing I'll be presenting this afternoon was the output of a project I did as part of the Clinical Leadership Fellow post last year with HEE, doing digital transformation and looking specifically, because it was with the School of Pharmacy North, around learning to work with these digital systems. Next slide, please. So just to, I suppose, explain what we mean when we're talking about digital skills, I got asked quite a lot as part of the project, do you want our pharmacy staff to code and to be able to speak in HTML? I was like, no, that's not what this is about. So this project was specifically looking at pharmacy staff's confidence, competence and capability to use digital systems. And it was all around making sure that people were able to provide the best patient care and improve patient outcomes and realise the benefits that digital systems bring. Next slide, please. So the aims were to define the real world barriers and facilitators to pharmacy staff developing that digital skill set. And I was looking not just at pharmacists, but pharmacy assistants and administrative staff as well that were involved in service delivery, the whole gambit really, and pharmacy assistant support worker roles as well. And the whole idea of that was to define those barriers and facilitators to then create some recommendations on how we could better set staff up and support them to enhance that skill set to use digital systems. And as I say, it was all around, I suppose, realising that the full potential of digital systems to deliver safe care. Next slide, please. So in terms of where I did this, I was sat within HEE School of Pharmacy North and was really keen to, having had this decades of experience in hospital sector, was to look further afield. And at the point of going into the leadership year, with the ICSs were coming into fruition, and it was all about collaborative care and working across the wider system. So I was really keen to do this project to look at pharmacy workforce skills across an ICP footprint. So I was really fortunate and able to recruit staff and participation in the Mental Health Trust in Leeds, secondary care, so in the hospitals. I managed to recruit people from primary care, CCG, GP practices, and also community pharmacy staff, so the whole gambit. And it was really great to hear from people across all sectors, because all I'd really known for years was wanted to see beyond the walls of the hospital. So that was great. Slightly difficult to recruit community and CCG pharmacy staff to take part in the workshop and conversations. So I had to use two different ways of collecting data. So managed to speak to quite a lot of senior leadership team across all sectors, and then managed to recruit coalface staff across mental health, primary care, some secondary care areas, but really struggled in terms of coalface staff at the CCG and community. So devised a questionnaire and did a survey. So I managed to capture some data across all sectors at both senior leadership level and also coalface frontline staff. And I was really fortunate. So I got 102 participants. So a huge thank you to everybody that took part, which felt great, really. Yeah, so the data, I managed to pull all the data together and use thematic analysis to try and, I suppose, shape and understand what was going on. Next slide, please. So there were lots of themes, and I think some of this is probably quite reflective of the work I've been doing during that leadership fellow year. I heard a lot in the data beyond, I suppose, the actual skill set and what in developing that meant. I think with all of these things, we now recognise that these things are multifaceted. So it was really clear that it wasn't just how we delivered training. Lots of factors impacted on how and whether staff engaged with technology to greater or lesser degrees. So the key themes that came through, people talked a lot about how they developed their digital knowledge and skill set to date. And that was really interesting to hear. There was a lot of talk about change, and I'll talk more about that in a second. People talked about how enabling innovation was important, and the fact that they felt not very well enabled to get involved in innovation and transformation, how that hindered their digital skill development. I'll talk a little bit more about risks in a second. The project, people did mention the technology as a barrier to digital skill enablement. There was quite a bit of talk about leadership in terms of what was needed and how important people felt that was. And then there was quite a bit that came out, unsurprisingly, I suppose, having looked across all sectors about the wider healthcare system and things, the barriers and facilitators that impeded or helped digital skill development across the system. So there was lots in there and way too much to talk about in the time available today. So I am going to talk mainly around theme 2 and theme 7, so the change element and looking across the system. But prior to that, next slide please, I just wanted to touch on theme 4, which was around the risks of not developing digital skills. And this was something that staff talked about unprompted. And it was something that came through for me as a bit of a call to action, I suppose, and really has pushed me to try and share the output of this data as widely as I can. And the things that people talked about were the fact that they felt, or recognised actually, that they really weren't using systems to the full potential. They were doing enough to get by and to get the job done, but beyond that, they felt that there was much more potential and that wasn't being explored. And that wasn't just in the areas they worked. They recognised this across other systems and across the wider healthcare system, because I spoke to people who had moved between organisations and sectors. I will talk a little bit more about that later. People talked about how, by not developing digital skills, they felt unable to really contribute to innovation and to improving things and using systems in a better way, so hindering innovation and that true transformation. And how, that people were limited by their own imaginations, I suppose, and people talked about the frustrations they felt and how dissatisfied they felt on a day-to-day basis, not being able to use systems well, and that could potentially cause burnout with staff. And I think the overarching thing that came through from all sectors was this feeling of the risk to patients if they weren't able to do this well, and people were feeling that on a day-to-day basis. So I suppose that's the main drive for me to share this work today. So next slide, please. So the first thing that I did want to talk about was supporting staff with change, and this is something that's really come to the fore for me over the last 12 months or so. Next slide, please. And the thing I asked people was, what do you foresee as the biggest challenge for pharmacy when it comes to digital skill development? And without hesitation, across the board, everybody talked about change and the fear of change, because that is the key emotion for the majority around change. And we talk about that, probably not really fully acknowledging it, but I think we recognise that change is difficult. So I was aware of that. But actually, when I looked at the data, that really came through. So next slide, please. And I think instead of giving you quotes, what I did with the data, what I'm about to read to you is something I called the Integrative Collective Perceptions, and it's a found poem about digital change. So the poem, the content of the poem are words and phrases or quotes lifted verbatim from interview transcripts, from people's written word in surveys and from the focus group discussions. All in response to the greatest barrier to digital skill development. So the poem goes: I had a member of staff who didn't have a smartphone. She was really nervous about it because she doesn't like the new change, a bit of fear of breaking the system, of doing something wrong, of harming patients. I don't have time, overwhelmed. I don't do computers. I'm a technophobe. How will I cope? Worried about how they are going to do their job. Worried it was taking their job. But then things do constantly change. It was introduced and it's a thing that is growing all the time. How we best use the systems changes constantly. Processes change. Someone's job becomes more admin, more ticking boxes. It feels like my actual role has changed. I think it is about time and breathing space and the ability to go through that grief cycle. So I think when you put the data together in that way, it tells quite a powerful story. And as I say, they were from across all sectors, from all types of staff, and all in response to the talk about change. And I think it really, I think for me, hammered home, when you put that together as a collective group of words, this is really quite significant and quite powerful. So next slide, please. And actually, this was really resonant of some work I did as part of my master's thesis, and this was over 10 years ago, actually, around describing what change happened when we implemented digital systems. And I think putting in an electronic prescribing system 10 years ago, we recognised that things changed, but we couldn't quite describe it or put our fingers on the what and the why. And this is something called an expansive learning theory, and I've overlain the pharmaceutical care and medicine supply process in hospital over the top of the theoretical model. And I think just it's a bit of a busy slide, but essentially at the top of the triangle you've got the prescription chart, which was the main thing we changed. So we went from paper to electronic, and this diagram basically shows all the interconnecting parts. So the pharmacist or the technician that's doing the work interacts with the patient and the prescription chart to deliver the pharmaceutical care or medicine supply. But underpinning all of that, we have laws and procedures that govern the what and how we do things. We are within an environment of some description, whether that's the dispensary or the ward environment, and we all have assigned tasks and jobs. You know, the labour is divided in certain ways amongst certain people. And one of the key things about this, and what this diagram really showed me or hammered home, was that if, you know, Engstrom, the chap who invented it, said that if you change one part of this, all of the interconnecting bits of it all have a tension and things start to wobble and it's not quite as stable, and it changes everything basically. And that really did help me understand and see that actually we changed that prescription chart, and it wasn't simply just a change in tool, it had a huge effect on all these other different elements and aspects. And you know, we've already heard today about how jobs have changed and people are doing things differently, and we could probably all recognise that in our own areas. But equally at the time, in terms of the ward environment, it completely changed how people were represented. So they talked about losing the power of the green pen and how they communicated messages. And I think, again, we've all recognised in terms of our processes, procedures, and even the laws around wet signatures and things like that, that has all changed or had to change in response to digital. But I think what complicates this even further is, as individuals, we all come from very different backgrounds in terms of education, in terms of upbringing, in terms of our exposure and our confidence with tech. So that is an added entity, I suppose, in terms of the complexity of this and how that can also contribute to the difficulties and the between all of these different elements. And what you can ultimately end up with is variation in practice and outcome. Next slide, please. And I think what was quite interesting in terms of change historically, and again, my main point of reference here is my experiences in hospital pharmacy and electronic prescribing. But when we tend to put these things in, we'd have a team of people, and we do a lot in terms of the, I suppose, the practical side of change. So we go out to tender, we choose the software, the hardware, the kit. We have a roadmap, we have deadlines, we deliver a bit of e-learning, and then we kind of get onto this treadmill of the implementation steam train kind of going through. And then once it's in, that tends to be the end of that for now, when we go to business as usual or maintenance of the system. And we're very good at that, actually. I think we do that pretty well. But I think in terms of my learning over the Leadership Fellow year and learning about change, I came across something called Bridges Transition, which talks about the kind of the practical elements of change, which is what I've just described, but he also talks about the psychological elements of change, and that's the bit that we don't do very well. And I think we've all come across Kubler-Ross's curve in terms of what people go through with change. We tend to have this kind of excitement followed by the sliding down to, gosh, this is hard, I'm angry, I'm depressed, and then people tend to come out the other side. And we've all come across things like Kotter's 8-step of change, you know, these things are quite helpful, but I think for me this really rang true and was really resonant and helpful when it came to digital implementation and the change associated with that. And what I like about this diagram is that it's not linear, and if you work from left to right, so at any one point along the journey you can be in any one of these three zones to a greater or lesser degree. There isn't really time to go into it in too much detail, but I think what I liked about it in terms of digital was this idea of, they talk about the ending or the letting go. So that's thinking about the old ways and our old identities, and just thinking back to what I've described in terms of what this means for individuals on a really fundamental level. There's a lot to work through there. So we need to help people identify what will change, and then help them in terms of letting go of that, to then help them move along to the neutral zone, which is, they call that no man's land. This is between the old and the new. So this is where we're kind of trying to let go of the old ways, and we're kind of identifying that there's new ways of working. It tends to be more when we're putting the kit in, and it's actually during this time, it's, you know, just as you're doing the implementation, and we've all seen this that have been involved in these projects, this is where the real creativity and the innovation happens. I think historically we've talked about this as people developing workarounds or not using the system in the correct way, but actually, you know, this is where the genius is really happening. And I think what I've recognised is that actually, you know, let's be engaging and working with people at that point to do transformation and process redesign, rather than waiting much later on, 6 to 12 months later, once the new system's in, and we decide to then to kind of, now we know how it works, let's do the transformation around this and think of our new work processes then. You know, we should be doing that kind of during the implementation and just after, to try and kind of capture the best of those, you know, how can we make this work for us as a team? And when you see individuals going and kind of finding new ways, bring that back to share that much more widely within the department or the wider organisational teams. So yeah, helping people through that kind of that neutral zone, embracing on that innovation, giving people time to really get used to that, and then people then be able to start with this new beginning. So this is where people start to identify with the new world, and they get this new energy and purpose, can really kind of take off with it. And I think what Bridges and Bridges say is that if we support people effectively through this, the transition, so this psychological aspect of change, they come out the other side much stronger, and they're much better adapted individuals who are more able and amenable to future change. And if we don't do this well, ultimately change can then become unmanageable. And when we think about, I suppose, the number of changes that staff go through on a day-to-day or month-to-month, and how complex things are in the NHS, you know, it kind of makes sense to help people in this way. Next slide, please. So if you just move on, next slide, please, sorry. So key recommendations in the document that came out from this project, this was recommendation 2 about really supporting staff with the change. And there's a lot on this slide, but the key messages here are that we need to change how we do change. It's about recognising the impact on staff to help them identify what is changing for them personally, but also for their work processes, and then recognising that in terms of changes to staff roles and being flexible and supportive, and using more emergent change processes in the moments during those times of creativity and innovation to really maximise on the technology and the benefits of the technology, and help with kind of staff development in their skill development in the moment. Next slide, please. So the other theme I did want to talk about was across the system, and by system, it gets a bit funny, doesn't it, with the language? So not digital systems, but the wider healthcare system. So this was looking across sectors, you know, transitions of care. Next slide, please. And I think one of the really interesting things that people talked about was this idea of commonality in product, but not in use. So this was about the same piece of software being used in different organisations, and I was really fortunate to come across a few people who had worked in different organisations or different sectors, but using the same system. Yeah, people that use the same system in the same organisation, but different buildings, if you like, as well. And people talked about the fact that when the same computer system was used in different organisations, the systems weren't configured the same often. And that meant that the functionality was very different. And in terms of learning to work with systems, that meant that that skill set that they'd developed was not transferable. So they'd used or learned to use a system, a clinical digital system in one place, had learned the where the loopholes were and where the problems were, and where they had to, I suppose, put those safety procedures in place to make sure that you know, they'd learnt the rules, I suppose, of the system and what it would and wouldn't let them do. And when they moved to a different organisation, because of the configuration being different, the kind of the little holes or the problems that they knew were different, and it meant that the system was functioning different, and they had to relearn how to use the same system differently. So that didn't feel very efficient, and people recognised that some ways of using it were better than others. And the other thing that was different is that despite having the same job role, they were assigned different access and user rights. And that again meant that they had to relearn how to do a job that would be considered the same or similar, but it was different in a different organisation. So this person said, I've worked in multiple places and areas, had good experiences across different systems, but that didn't always translate into compatibility or being able to use the next one when I moved. So that didn't feel like, in terms of helping people develop that skill set and get the best from the system, the computer system, that didn't feel helpful. Next slide, please. And just to, I suppose, extend that a little bit more, that then also meant that people felt that their jobs had changed. So a pharmacist talked about having less access rights, so wasn't able to do as much when they moved from one organisation or one sector to another. And it felt their role had completely changed, and they'd gone from being really proactive and being able to change prescriptions in a really proactive way to not really being able to do very much. And they felt kind of pushed a bit more kind of into the background, and felt like they were nagging all the time to get things changed, and felt a lot less able almost to really deliver the care they wanted to. So they felt that their role had completely changed just merely by the fact, you know, same computer system, but their the setup of the system and their role, what they could do in their role, was different. Next slide, please. And then a couple of final points was around the data entry, use and translation across the wider healthcare system. And there's a lot on this slide here, but the summary of it is that patients described how the same system used across different organisations was set up and viewed differently. So that really, people talked about the fact that that affects access to certain types of information for people. And, you know, there was this real feeling of, you know, don't just assume that because you've put something in the system that it's going to be read, because the person that you want to read it might have things set up differently at their end. They might not see it, they might not even know that it's there, and that just feels really demoralising. It doesn't feel very safe, and actually, how can we improve that and make this more efficient and safer? Next slide, please. And that really came through in terms of this, you know, actually, what do people see and who uses that? You know, and as I say, even though it's the same product, why are we all looking at it differently? So that was really quite interesting. And a primary care pharmacist said, it's cross-working, isn't it? I think we need to have an understanding of what information you put on, and just, I suppose, knowing and understanding that that can impact a patient somewhere else in the journey. So there was a real sense of concern about that. So who sees what, who uses it? Do they know it's there? And actually it then started to go down, well, actually, what's the point? I've spent hours looking up this information and trying to create this picture of what's gone on for this patient. I've documented it, and then my genuine belief is that nobody's read that, and that doesn't feel very efficient either, and very frustrating, and caused a lot of low morale. Next slide, please. Yeah, just next slide, please. It's all one in the same, just conscious of time. So the final, well, the recommendation around the cross-system working was just to have more collaboration, and to share innovations and best practice. And all of that really should support this, I suppose, the enabling the development and innovation, but equally in terms of transferability of digital skill set for staff, if they move across, you know, even within the same organisation, across departments, or, you know, move from one sector to another, it seems that we could be a bit more efficient and collaborative in terms of how we share this stuff and support our staff to use systems well. Next slide, please. So in conclusion, I suppose my key messages are: let's change how we do change. Let's enable innovation as part of enabling change. And let's work together more collaboratively across the wider healthcare system to really try and support staff and enable them with this digital skill set development. The final slide has got my contact details, so please do feel free and able to get in touch. There is hopefully a publication coming in and around this work, because there is so much that I have not talked about, but yeah, more to follow, I suppose. But if you had any questions, then please do get in touch. Thank you very much.
Thank you, Angela. That was really fascinating, and good timing as well. So yeah, there's quite a lot in there, to be honest, in the past 25 minutes. So there was obviously a lot of research, kind of the outcomes from that. There's also touching on the academia side, like costs of ASAP to change and bridges. And there's also some poetry in there as well. So yeah, well done. It's quite a large, packed presentation there. So we just got a couple of questions, I think. So one of the questions came from Megan with regards to, let me see if I can find it here. Wait a second. So Megan was asking about, do you feel there should be kind of standard RBAC expectations set by NHS Digital, either a minimum or maximum level of access to people with specific clinicians? They found assigning RBAC quite challenging because of how different users currently work and how we want to work digitally. Any thoughts on that, Angela?
Yeah, I'm just pondering. It's a difficult one, that, isn't it?
Yeah.
So, yeah, I mean, I wouldn't like to say one way or the other. I think it's, I think what's hard about this, I think thinking about the wider system, it feels like there should be probably more of a standard streamline approach, because I think that cross systems working is probably a good example of access to systems, and how, you know, even people with the same, you know, even a pharmacist who's doing the same level, so I'm sorry, just excuse my language around this, but the level 7, a band 7 pharmacist doing a band 7 pharmacist in one sector, one organisation, moving somewhere else, still qualified as they were the day before in the other organisation, you know, their access level was very different, and it meant that their access to information and their ability to manipulate stuff in the system was very different. And why is that different? I don't know what that's about. So it makes sense really to, you know, to have a level of standardization to make sure that all staff, you know, if they've gone through the necessary training, are able to access patient records and do what's needed to be done in the same way. I don't know if that really helps, but.
No, I think it does. I think it's, like I said, it's not an easy question to answer. I think from what we've seen as well, and from the implementations we've carried out, just speaking personally, that you may have some sort of standard RBAC roles, but then there may be kind of additional functionality that you might need. And obviously now with kind of the new roles like of advanced clinical practitioners as well, it's just something to take into consideration. So I think this whole area is ever evolving. It's just useful to have information at a time to do something that's of a standard manner, but then there needs to be an ability to be innovative, change and flex as and when the requirements arise. So yeah, so thanks for that. Just trying to see, and the other, I think just want to say, it's conscious of time, so the other questions that will be put into the chat, we'll put them on a futures page, and so those questions will be will come out to yourself, Angela, to Jim and Penny as well, to say answer them. So yeah, I just want to thank you all for your time today. It's been really enlightening to see, you know, the kind of innovation that's available. Just to give you a heads up to the next masterclass. Thanks for that, Sarah. So in August, with everyone being away usually during the summer holidays, the next masterclass is going to be on Wednesday, 20th of September, and that's going to be around the ePrescribing tool. So our colleagues in Newcastle have done some really phenomenal work, and so this is kind of relates back to the change and how we can optimize systems as well. Excuse me. So yeah, and the head of patient safety will be there as well. So just want to say thank you very much to everyone for your time today, and look forward to catching up with you on the next masterclass on Wednesday, the 20th of September. Thanks again.